I wanted to thank Oliver Wyman for an excellent presentation, rich with data, really advanced the information that's a central key theme to this hearing. Specifically, Jen Smagula, Linda Reed, and Linda Keene, right? And Don Gorman. So I really appreciate it. I'd be remiss to not acknowledge our health insurers in the state who provided the data to inform that great report. Specifically, I wanted to acknowledge Harvard Pilgrim Healthcare, which I think we're all aware had an unfortunate data breach earlier in the year. And I wanted to acknowledge and state my appreciation for their hard work and effort in rallying up to provide all the important data for the report. So that's not unnoticed by the insurance department. Okay. So now we're on to the second part, our price transparency symposium. So we're delighted and excited to help shed some important insights related to price transparency in healthcare. This concept is not a new one, nor is it without its skeptics and cynics. We expect that after our panel of speakers have presented, you will develop important new insights about the reformative potential of price transparency. And we are optimistic that now, with several new health policy shifts, price transparency in healthcare does indeed hold strong potential to bring our healthcare markets to a more optimal level of function. A little bit of housekeeping. Just as before, remote participants can submit any questions to the panelists using the chat function in Teams. And for in-person attendees, please raise your hand and an NHID staff member will bring you an index card so that you can submit your question in writing. Then after all three presenters have shared their information, we'll ask those questions to them here at this panel. We've structured the order of the presentation to take on a logical sequence, reflecting the use of price transparency by consumers, employers, regulators, and policymakers, and providers. First, we've invited Dr. Brown, Assistant Professor of Economics at the University of Michigan. He's here to share his perspective on the economic effects of price transparency. Dr. Brown published a seminal paper using claims data from New Hampshire, and he offered empirical evidence of downward price pressure on a cohort of radiological imaging services within 2 years of being posted to New Hampshire Health Cost, which you probably know is New Hampshire's flagship price transparency website. I welcome Dr. Zach Brown to the podium.
Great. It's a pleasure to be here. So today I wanted to talk about some of the economic effects of price transparency. So I think most of us know that high prices are a fundamental concern in healthcare markets. You know, they're a primary reason why we see such high spending among the commercially insured. And historically, a majority of people say that they do not compare prices before receiving medical care. We also know that certain providers and hospitals have significant bargaining power with insurers, and we see pretty high prices for certain providers. And there's a lot of work showing that there's large variation in prices for similar procedures. So even for very standardized procedures like upper body MRI, we see large variation in prices. One study found that nationally, 10% of individuals pay less than $700 for an MRI. However, there's 10% of individuals that pay over $2,000 for the exact same MRIs. My work focuses on New Hampshire. We also see large potential savings for medical imaging procedures if individuals switch to lower cost providers in New Hampshire. Individuals could often save 50% or more for if they switched. And this is similar for other procedures. We also see large variation in prices. And so there's been this kind of natural inclination that maybe giving patients access to price information through price transparency tools can allow patients to shop around. There's also been some skepticism about whether patients will actually use these tools. Today, I wanted to talk about some of the evidence related to consumer shopping, but I also wanted to talk about other ways that price transparency can affect healthcare spending. I think Chris Whaley will also be talking about these issues. First, I wanted to talk about the broader economic evidence on whether information about prices can lead to lower prices. And so we now have a lot of evidence from various markets that when consumers can go online, easily compare prices, that increases competition. So for instance, when individuals can shop for life insurance online, we see more competition. When individuals can shop for cars online, we see lower prices, more competition. In certain countries, they've required supermarkets to post prices online. We've seen more competition there. Food prices have gone down. Certain countries like Germany have also required gas stations to post prices, made it easy for consumers to compare prices of gas, find the cheapest gas station. Some recent work finds that in Germany, when gas stations were required to do that, prices also went down there. Now, we have all this evidence from various markets. How about healthcare? You know, there's a sense that maybe healthcare is different. It's particularly complicated. You know, there's concern about whether patients will actually use these tools. I think it's important to note that there's now a variety of price transparency tools out there. We have privately provided tools, such as tools that are implemented by employers. We have state-level tools, such as New Hampshire's price transparency website. And then we have recent federal-level initiatives requiring providers and insurers to post prices. Those federal-level initiatives are still kind of in their infancy. Now, we have a growing number of studies looking at both privately provided tools and state-level tools. And so I just wanted to point out that not all price transparency tools are equal. And we would only expect price transparency to be useful if it's easy to use, the information is fairly accurate, it's widely accessible. And this is not the case for many price transparency tools, which might explain why, in some cases at least, these tools are not widely used yet. So focusing on New Hampshire's tool, I think most folks here are probably familiar with New Hampshire's price transparency website, but just to remind folks, it's quite easy to use. You go on the website, select what procedure you're interested in, put in your insurance information, and then it gives this estimate of the procedure cost at various providers. And so here I've inputted CT scan of head brain without contrast. We see large variation in cost across providers. I think this is particularly easy to use. It's always difficult to estimate procedure cost, but this is based on actual claims data, potentially more accurate than some other tools. So what's the effect of this price transparency website? Well, there's survey evidence showing that a majority of patients that use the website do report saving money. My work focuses on the overall effect of the website on spending, looking at the period around the introduction of the website in 2007. And this is so that I can compare spending prior to the website and after the website. I focus on medical imaging because these procedures are quite standardized. and it's easy to look at similar procedures that are not affected by the website, for instance, those in other states. And I think it's important to note that the website includes other procedures than just medical imaging, and actually the list of procedures on the website has expanded over time. And then I use the kind of claims data, the detailed claims data to look at the effect of spending and prices. You know, researchers having access to this claims data, I think, is incredibly important for this type of work. All right, so what do I find? So this shows the percent change in spending or allowed amount before and after the introduction of the website. And the black line shows the period when the website was introduced. So kind of relative to spending for procedures that are not affected by the website, we see this decline in spending over time. And it kind of grows over time and is eventually about a 4 or 5% reduction. And so what's going on here? Well, there's some evidence that at least certain individuals, particularly those that might have the most incentive to use the website, are saving on out-of-pocket costs. In particular, those with high deductible plans. These are individuals that have the most to gain from shopping around, do seem to save on out-of-pocket costs after the introduction of the website. You know, savings for others is smaller. There's also some savings for health insurers. I think these results are broadly consistent with some other evidence, including those for kind of quality privately provided tools, that for those that actually use these tools, there is significant savings to be had. One of the main findings from the study is that overall, there's a statistically significant decrease in prices, in rates. And why is this important? This is important because we know that a lot of individuals don't use these tools. So even for the individuals who are not using a price transparency tool, they're going to benefit from these lower prices. You know, if price transparency is able to constrain rates. I also find a larger effect on prices in concentrated markets, provider markets. This is also, I think, what you would expect. You know, in markets with only a few providers, you can imagine prices are higher. We have a lot of evidence that, you know, higher prices is associated with more provider concentration. And so these are the areas where price transparency might be able to particularly constrain rates. I think it's important to point out that the effects are initially fairly modest, but they do seem to be growing over time. All right, so why could price transparency constrain prices? Well, you know, the first mechanism here is that if at least some individuals shop around, such as those with high deductibles, this could be enough to put some pressure on providers to reduce or at least not increase rates. Second, I think that there's this issue of regulatory scrutiny. You know, if regulators can see which providers have high prices, this might also put some pressure on providers. And then finally, there's this related issue of kind of the threat of bad press. We've seen many examples of journalists using this data to provide information about which are high-cost providers. Now, there's a bunch of examples. Here I'm showing you one article from kind of around the introduction of the price transparency website. And this journalist is using data from the price transparency website to point out that at least the hospital that's the focus of this article has higher prices than peer hospitals. And you could imagine this type of attention could kind of spotlight providers that are particularly high cost and put pressure on those providers. I also wanted to just highlight how other states that have price transparency tools, the number of states with price transparency tools has been increasing over time, but many of those tools are not comprehensive. They're what some have called a partial price transparency. The tools are difficult to use, don't provide that much information, very limited number of procedures. New Hampshire is still somewhat rare in that they have this pretty easy to use, comprehensive tool. And so I think that's one, despite the fact that people have been talking about price transparency for a long time, it's actually not as common as you might think. So I think there's this broader question of, is there scope for larger effects of price transparency in the future? I do find this evidence that the effects seem to be growing over time. And I think there's a number of explanations for that. First, price transparency takes time to become the norm. Patients have to get used to actually using these tools. It might take time for people to figure out kind of which are the high cost providers. There's other mechanisms by which price transparency could affect spending. For instance, employers could use the information when designing benefits. I think Chris will talk more about that. Also these tools kind of continue to be improved over time as there's better data, more user-friendly websites, and so on. And in particular, the use of kind of insurer-posted prices might further improve these websites. I'll also mention that price transparency could have a larger effect if combined with other interventions. So there's kind of a growing consensus in economics that provider competition is really key to constraining prices. If there's a monopoly in a given market, then price transparency is not going to have any effect. If individuals can't shop, if there are no choices, then we wouldn't expect price transparency to do anything. And so really provider competition is kind of a necessary ingredient for price transparency to have any effect. And I think there's kind of this idea that provider competition is really core to constraining prices. Finally, I'll also mention only some individuals have an incentive to shop. Only some individuals can actually save on out-of-pocket costs. And so, particularly those with, say, high deductible health plans. So that's also an issue that could potentially increase usage of these tools in the future. And then finally, there's a lot of, physicians that refer patients to specialists. Patients might not even be aware that they have much choice. Educating or potentially even incentivizing physicians to give patients choices when they refer patients to a specialist could also increase the effect of price transparency tools. So I think I'll wrap up there, and I'm looking forward to questions.
Thank you. And as I said before, if you're on Teams, you can put your questions in through the chat function. If you're here in person, you can raise your hand and somebody from NHID will come up with an index card. We'll put them in writing and ask them to the presenters after all three have shared their great information. I did want to acknowledge one important thing. Thank you, Dr. Brown, for highlighting New Hampshire health costs. I'm very proud to be working on it. And I wanted to point out two individuals sitting here in the crowd that don't need any introductions, but were pivotal in starting this important movement. And I did not know that price transparency websites or comprehensive price transparency websites weren't that there was only two in the country, and I'm proud to be working with one of them. But Alex Feldwebel and Tyler Brandon here started all of that, and I am proud to call them friends and mentors. So I think everybody needs to hear that, know that, and yeah. Enough about that. So now I'd like to introduce Dr. Chris Whaley here in the audience. He's Associate Professor in the Department of Health Services, Policy and Practice at the Brown University School of Public Health. He's also a health economist at the RAND Corporation. His research focuses on healthcare price transparency and market structure. It has been published in leading clinical, health policy, and economics journals. Today, he will present novel data that demonstrates how large employers may use price transparency to negotiate better prices for their employees. Dr. Chris Whaley.
Great. Thank you for inviting me, Jason, and really excited to be here. So today what I'm going to talk about is a series of studies that we've done using data mainly from large employer plans, but also from state all-payer claims databases, particularly the New Hampshire APCD. So New Hampshire, the New Hampshire APCD was actually the first APCD that we were able to include in the study. And I think out of the scope of APCDs across the country, the state of New Hampshire has the APCD that is most accessible to researchers, and the environment to use the APCD has been fantastic. And so I'm sure Zach would agree. But a lot of what we know about healthcare markets using APCDs actually comes from the state of New Hampshire. So as a profession, we thank you a lot. So excited to talk about what we've done with some of that data, in particular looking at prices for hospital care for employer-sponsored individuals or people who receive insurance through an employer. This is a huge and important market. So across the country, employers provide coverage for about half the country, about 160 million people. And collectively, employers spend about $1.2 trillion on healthcare costs, with the largest chunk of the pie, just under $500 billion, going towards hospital care. So when we talk a lot, especially the state level on policies, in healthcare policies, we focus a lot on Medicaid, and the federal level on Medicare. But the employer-sponsored population is, I think, really left out of a lot of policy discussions, even though this is the largest source of coverage in the United States. And it's also a market that is not just large and important, but has had many problems. And so if we look at where that $1.2 trillion comes from and how it's financed, it comes directly out of worker paychecks. So how individuals receive insurance is the employer has a kind of overall benefit cost, and some of that goes to take-home pay, and some of that goes to healthcare costs. And as we've seen healthcare costs go up over the last several years, that amount of take-home pay has really decreased quite a bit. So just looking at data from the Kaiser Family Foundation, over the last decade, the amount or the share of deductibles has increased by about 160%. It's not uncommon for many employer-sponsored deductibles be $5,000 or more, and individual market deductibles be $10,000 and more. And so, particularly for lower income individuals who are much more exposed to these huge deductibles, this is a really concerning problem for access. Premiums have increased by over 50%. It now costs about $25,000 for an employer to provide health insurance for a worker. Again, if the median wage is around $50,000 and you're spending half of your money on your healthcare premium, then that's concerning for how we finance the healthcare system. And worker wages have actually increased less than inflation. So in this huge and important market, we're essentially financing healthcare spending by taking money out of worker paychecks and paying workers in healthcare dollars. So I think this is something we need to be concerned about. And so how we've tried to approach this question is working with employers and helping employers understand what is frequently called to is their fiduciary responsibility. So if you're an employer, you're providing health insurance for your workforce, and in doing so, you're taking money out of worker paychecks and paying workers essentially in healthcare dollars. And so as part of doing that and being a purchaser of healthcare benefits, you have a legal obligation as an employer to make sure that that purchase is actually fair and efficient. And if you look at the Department of Labor website, there's a pretty clear definition that fiduciaries, in this case employers, have an obligation to act solely in the interest of their plan participants, so their workforce and the worker or their dependents, with the exclusive purpose of providing benefits towards them. So if you're an employer who, collectively is responsible for, spending across the economy over $1 trillion in healthcare, and you have no idea on what prices are, it's not clear that you're actually able to fulfill this fiduciary obligation and be a responsible purchaser. And so in the study that I'm going to talk about today, what we've really tried to do is help employers fulfill this fiduciary obligation and be responsible purchasers of healthcare on behalf of the workforce. And just another thing to point out too, states in many cases are the largest source of employer-sponsored insurance in their market, and also have the same strong fiduciary obligation to make sure that as providers of insurance that they're using dollars wisely. And so to help employers fulfill this obligation, what we've done is a series of studies. I'm going to talk about the fourth round of our study, where we've collected data from across the country, mainly from employer plans. So the employer plans in the data range from basically small mom and pop manufacturing companies to some of the largest employers in the country with lives in every single state. We've also been able to include data from all payer claims databases. As I said earlier, we started out with just the New Hampshire and Colorado all payer claims database, but have been able to expand it to 11 different APCDs. And then we've also, in some cases, been able to get data from different health plans. So we were able to collect all these data sources from across the country and spend a lot of time kind of standardizing. And you imagine that if you get data from one source, it's quite different from another source or another employer. And so we try to make sure that everything is standardized and comparable. Then we look at hospital prices in two different ways. So first, we have relative to a Medicare benchmark. And so the way to think of this is that we're looking at how much is an employer paying for a given claim or service at a hospital, and how much would have Medicare paid for the exact same service at the exact same provider on the exact same day. The advantage of this approach is that Medicare adjusts for a lot of the things that maybe we think are beneficial in comparing costs. So if it's expensive to hire doctors and nurses in one area, or if patients are sicker or a hospital has a unique cost structure, then Medicare adjusts for a lot of those types of differences. And so it's relative to kind of this common benchmark that makes us have kind of an apples to apples comparison. A point on the percent of Medicare benchmark. This is a benchmark, not a price endpoint, and so I don't think it's appropriate to say that prices should be exactly what Medicare pays. But Medicare is kind of a common denominator that allows us to compare hospitals across the country. So if we see that one hospital is, say, 200% Medicare and another hospital is 300% Medicare, that's a pretty easy way to understand which hospital is more expensive. For some employers and purchasers, maybe they're not interested in a lot of these additional payments that the Medicare system adds on. And so we also have a case mix adjusted or a standardized price difference where we're saying, we're not going to deal with the wage or geographic adjustments that the Medicare puts in. We're just going to do some adjustment for patient complexity and procedure differences and have just a dollar difference. And so with these data sources, we've basically shared results in two different ways. So one is through a public report on the RAND website, where we actually have a kind of high-level summary of findings, as well as a data set that actually has prices for about 4,000 hospitals and about 2,000 ambulatory surgical centers, where we kind of try and slice and dice prices in a bunch of different ways. And if this data set is too complex, we've also created this dashboard called Sage Transparency, where you can actually go through and actually look at prices individually through this online website. And then additionally, for employers, we also have a basic report that says, look, maybe you're not concerned about what prices look like across the country, but you want to know what prices look like for your individual population. And so we give employers information on what prices look like among their plan. This is the fourth round of the study. We're actually just in the midst of our next round and are hoping to have that ready by May of 24. And so what did we find? So across the country, prices range quite considerably. So just looking at state averages, the average price is about 250% of Medicare. So employers are paying what Medicare pays, and then 1.5 times above that, and so that's a fairly large difference relative to the national payer of Medicare. And then another thing that's just I think incredibly surprising is the large variation in prices. So if we look at the lower end states like Hawaii, Arkansas, and Washington, prices from relative to Medicare are about 150 to 175% Medicare. On the upper end, in states like Florida, West Virginia, and South Carolina, prices are closer to 325% of Medicare. So keep in mind that this is a huge and important market that accounts for billions of dollars in spending, and we're seeing almost a 2x range in prices across different states. And it's important to think about what drives this type of variation and whether we're getting what we pay for. Certainly, hospitals in Seattle are able to function at around 175% Medicare, and it's not clear that hospitals in, say, Tampa or Miami are that much better that warrants the 2x difference in price. New Hampshire, which I've highlighted here, is actually a little bit below the national average at about 210% of what Medicare pays. So certainly higher relative to Medicare, but compared to other states, the price differences aren't quite as large. We've also separated prices into facility and professional fees. And so if you go to the hospital and get a bill, there are two components that come in. So one is the bill from the hospital, and that's the stay for the room and the device or providing the operating procedure. And then there's also a professional fee that essentially covers the physician's time. And just kind of looking across the board, facility fees are about 80 to 85% of total hospital bills, and professional fees are the remaining 15 to 20%. And so if we just look at the part of the bill that comes from the facility, across the board, prices are a little bit higher. So relative to the overall facility and professional price of around 250%, on average, it's about 270 or 75% for just facility fees. Here, New Hampshire actually moves up a little bit. Facility fees in New Hampshire are about 225% of Medicare. So again, below the national average, but higher than Medicare by a considerable amount. And if we look at professional fees, and so this is the amount that goes to the doctor for a hospital bill, across the board, we see two things that really stand out. So one, prices are quite a bit lower. And so relative to the facility fee average of about 275% of Medicare, professional fees across the country are about 150 or 160% of Medicare. So in every state, clinicians get paid quite a bit less than what hospitals get paid for services. The other thing that really stands out is, with the exception of a couple states on the upper end, there's just much less range in prices for professional fees than what we see for facility fees. And if we look specifically at New Hampshire actually has the fifth lowest professional fees at about 125% of what Medicare pays. And so physicians and clinicians in New Hampshire are getting reimbursed at roughly what Medicare pays. An advantage of using data, and especially the APCD data, is that we can actually look at prices by individual providers and, in some sense, name names. And so while we saw that on average, prices in New Hampshire are just over 200% of Medicare, the same range in price that we see across the country also exists for New Hampshire hospitals. And so if we look at the lower end, North County healthcare is about 150% Medicare. While at the upper end, HCA and LRG are close to, or in the case of LRG, actually above 300% Medicare. So again, even among hospitals in the state of New Hampshire, there's roughly a 2x range in prices. And while that variation exists across the board, if we look at just individual services, so here in the case of orthopedic surgery, we still see lots of variation. And so what we have here is in the blue bars, the price relative to Medicare, and in the red line, that standardized price that I mentioned, that's the not incorporating all the Medicare payments and just the dollar difference. And so relative to Medicare, getting a joint replacement or other orthopedic surgery is again around 150% Medicare at the lower end, all the way up to over 600% of Medicare at the higher end. So again, that's a pretty large variation in prices. And if we look at dollar amounts, again, around $20,000 or so at the lower end to above $60,000. And so again, really important to think about what drives this variation and whether or not the orthopedic surgery at the $60,000 provider is much better than the orthopedic surgery at the lower end of the $20,000 or $30,000 provider. And economists have actually spent a lot of time, especially in recent years, trying to understand these questions. And the punchline is if we look at what drives prices, there's really no correlation between hospitals' share of patients that are on Medicare or Medicaid. And so this is commonly referred to as cost shifting. And so one argument among particularly higher price hospitals is that we treat lots of patients who we lose money on. And so we just kind of, to stay in business, have to charge higher prices for commercial payers to offset those losses. So economists have spent a lot of time looking at this question and really not found any evidence, or have not found any evidence to support it. There's also some, but pretty minimal correlation between hospital quality. And so higher price hospitals do tend to have slightly higher quality, but the difference isn't actually that stark. And as Zach mentioned, where we do see pretty strong relationships is with market power. And so hospitals that are in dominant market position are ones that are able to command higher prices. And just to touch on the cost shifting argument, so we actually looked at this in our data. And so what we did is across the 4,000 hospitals in our study, we're able to use data that hospitals report on what's their share of patients that come from Medicare, Medicaid, or uninsured or charity care, and the hospital's price relative to Medicare. So if it's the case that hospitals that have lots of non-commercial patients, so lots of, say, Medicaid patients, and those are the ones that are presumably the hospitals are losing money on, then what we should see is that the hospitals that have lots of those patients are the ones that have the highest prices, and hospitals that have, fewer Medicare patients or Medicaid patients are the ones that have the lowest prices. And so we should see an upward trend in this chart. At least when I look at this, this is essentially a random scatter of dots, and we do all the statistical tests. We don't find any relationship here. And I'll skip this just in the interest of time. But we've also looked at other studies, or we've done other studies that find that when hospitals increase their prices, quality and safety does not go up. And so as we've been doing these series of studies over the last several years, it's been really interesting to see how employers and purchasers have been actually able to use price transparency. And so as Zach mentioned, one use of price transparency is to kind of enable consumers to be smarter shoppers. Another use of price transparency is upstream of consumers and to allow employers to design better benefits, as well as policymakers to shape markets that are more favorable for patients and consumers. And so the way I kind of see the use cases on that kind of upstream dimension is kind of a continuum of use cases. So on one end, some employers and policymakers are just kind of excited to have information on prices and kind of think about it a little bit more. Other employers have actually gone out and benchmarked prices through mainly innovative insurance benefit designs. And then finally, some employers have actually used price transparency data to change networks and to change some of the contracting practices that happen on their behalf. So just on the first point, one I think really good example of just kind of having information on prices actually comes from the second round of the study, where we were able to look at prices in 25 different states. Here, a group called the Colorado Business Group on Health took that data that we had on prices, hospital prices in Colorado, and basically combined it with quality information that they've been collecting on Colorado hospitals, and proposed a series of recommendations to the state, as well as policymakers. And so this kind of sat in the policy kind of drawer for a while, but then actually in the last year or two, the state of Colorado used a lot of these policy recommendations to implement a public option, and the state of Colorado Employee Health Plan formed essentially a co-op with large employers in the state of Colorado to jointly purchase healthcare benefits. The second point on this continuum is to just think about networks and to think about prices that are in their market. So when we did the first and second round of this study, one of the things that we really highlighted is that in the state of Indiana, there is a large range in prices for outpatient care for services. And so what would happen is a group of 12 employers in the state of Indiana essentially saw that data and said, look, we want to do something to make sure that we're not wasting our employees' money on healthcare. And so they designed a tiered network that essentially caps prices relative to Medicare for outpatient care. And we're able to expand this across the state and bring in quite a number of hospitals and to bring prices down quite a bit. And then the final kind of employer point on this continuum is just to think about prices that are negotiated on employee or workforce's behalf. So many employers rely on brokers, TPAs, and others to negotiate prices and really have little insight into what goes on behind the scenes. And so when we did one of our studies, we highlighted a particular hospital system in Fort Wayne, Indiana, that we identified as the most expensive hospital in the country. Their prices were over 400% of Medicare, and so that's pretty high. And so this got a lot of coverage and attention, but employers in Fort Wayne essentially saw this and were none too happy and went back to their insurer and said, why are we paying you a monthly fee for you to go out and negotiate what are probably the worst prices for healthcare or the highest prices for healthcare in the entire world? And so they essentially said, now that we have the data and we can see what's going on under the hood, if you don't do a better job of negotiating prices, we're essentially going to go to a different carrier. And so this led to a new contract between this hospital system and the insurer that's supposed to bring prices down or bring spending down by about $600 million over a 5-year period. And then just the last point too, and this dovetails nicely to what Maureen's going to talk about, is policymakers outside of kind of their purchasing power can actually use price transparency to make sure that markets are fair and competitive. So again, in the state of Indiana, there's been a lot of activity using these types of data. And what's come out of this is policies that essentially ban a lot of the anti-competitive insurance provider contracts that lead to high prices, as well as things like allow physicians to work for other hospitals without having large non-compete buyouts, and also benchmarking prices relative to Medicare and putting some downward pressure on prices. And so just to wrap up, I think that rising healthcare costs place a tremendous amount of pressure on worker wages and how business operates, especially as we come out of the pandemic. The kind of glass half empty view of a lot of this work is that there's a lot of waste in healthcare through price variation, but the glass half full view is that that's actually a pretty important savings opportunity. So if you can design policies to either get higher prices down or to send patients to lower price, high quality providers, then that's a substantial source for savings. And then finally, I think it's really important that we have data resources, including the APCD in New Hampshire and other states, that allow employers and policymakers to have insight into prices. Awesome. Thank you, and looking forward to questions.
So thank you, Dr. Whaley. What a powerful message on the importance of data and the power of data. So that resonated with me. So I wanted to mention that these presentations are going to be posted on NHID's website. They're probably there now. If not, by the end of today's presentations, they'll be up there. And also, don't forget to ask your questions, right, while they're fresh in your mind. Fresh is best. So just put your hand up and some of them come up to you. If you're here in person, you can write them down. If you're on Teams, put them in the chat bar, because we really wanted to tailor this to you and what you want to know. And I've got lots of questions in my mind, but I'm more interested in learning what you want to know. So don't forget to do that. Okay, so now we'd like to invite Maureen Hensley-Quinn from National Academy for State Health Policy, or NASHP, up to the podium. Ms. Hensley-Quinn leads the coverage, cost, and value team that focus on states' efforts to finance coverage, ensure access to quality, and strive for affordability for individuals and other healthcare purchases. Today, she'll introduce a unique utility that NASHP helped develop and describe examples of policy levers that states may apply to exploit ongoing price transparency efforts. Maureen Hensley-Quinn.
Hello, thank you so much for inviting me to be here, and thank you so much for putting me at the end so that I could follow two incredible speakers and then really balance off of what Chris just shared. Okay. So NASHP, just to give you a sense of the organization, we are really all about states. We're a national nonprofit organization, really for and about states. We have literally an academy of state policy officials. They represent departments of insurance, legislators, governor's office, Department of Health, Medicaid, really any place in the state that touches health. We are lucky enough to have representatives across the country to guide our work. And in guiding that work, they really ask us to do research and also develop tools. So that's what I'm going to highlight today. So as we were convening our academy back in 2016, we asked, what is keeping you up at night? And they said prescription drug prices are keeping us up at night. So we started working to pull together data, to pull together policy solutions. And we sort of gut checked with folks in 2018 and 19 saying, so how are we doing? What are you focused on now? They said prescription drugs is still incredibly important to us. However, as we look at all of this, the largest proportion of our healthcare dollar is going to hospitals, and hospitals are increasingly buying up physicians. And so there's where our dollar is going. We need help with that too. So with Arnold Venture Supports, we continue our work on prescription drugs, but we created a center that really does exist online, but is driven by state policymakers to help answer the question, what are states paying for? Should they be paying that much? And then to understand what some policy tools might be to address some of this. So as we dive into hospitals, we often think about hospitals having one revenue stream. What we as patients or care purchasers pay for patient services. But it is important as we're thinking about hospitals that they have multiple revenue streams, and they should. It's a good thing that they have multiple revenue streams. But as we talk about trying to squeeze one part of this to get more affordable care, and hopefully more affordable health insurance premiums as a result of getting more affordable care, that we're not talking about completely underpinning, completely pulling the rug out from under hospitals. There are many different revenue sources, and we need to think about it more holistically. But I just want to flag that what we're talking about and what I'm going to focus on today is really the patient revenue. So as we started working with states, they said transparency is the most important thing. We don't know how much the care costs. We don't know how much it costs hospitals to provide that care. And as we're talking about lowering prices or reimbursements for patient care, we don't want to harm hospitals. We want to keep them open. We want to keep the care to be high quality. How do we know what it costs them to provide that care? And my colleague, Marilyn Bartlett, who is a CPA and looks at this literally through debits and credits numbers, said, you know, we could use the Medicare cost report that every hospital has to complete on an annual basis when they receive Medicare payments, and they send that to the federal government. We could use that to understand what their costs are. And so she dove in to do an analysis of Medicare cost reports. The result is our hospital cost tool. We developed that over a 2-year period, really working with state officials, sharing the information that we were learning, asking what would be helpful to them. We released the hospital cost tool in 2021. And we are now doing an update for the 3rd time to that tool. At the time, we could release data from 2011 through 2019, because that's what was available. Now we have data 2011 through 2021. We are currently working to pull together data from 2022. We don't do it alone. I just want to also add, we are really policy folks at NASHP. Marilyn, again, CPA, but we work with Rice University, who helps us do data validation with their health economists and statisticians, and then Mathematica helps us create the tool and visualizations that people can use. Here's an example of some of the things on the tool. So I literally cut and paste from what's on the tool. It includes over 4,000 hospitals. It includes a ton of information on those hospitals. One of the metrics is operating margin. I will underscore that the data that you're looking at is related to hospital or facility costs. It doesn't include physicians that bill separately. It also focuses in on patient care. So we're not looking at overall profit margins that can include things from external pieces, like if they own property and they're making money off parking or things like that. That's not included in this. This is patient services data. So it's not meant to represent that this is a hospital's overall profit. This is just on patient services for the hospital facility. So as you can see, national versus New Hampshire, the lines actually are relatively close. We see across the board in 2020 that there were dips in profit, that there were changes to overall financial metrics across the board. Obviously, a lot happened in 2020. We're looking forward to getting the data from 2022 to understand how these things balance out. It was already stated earlier today that in 2021, huge spike in utilization. So you see some changes related to that. So now we're going to dive in to a little more specificity. So we have found that looking at hospitals by their bed size is actually a very important thing to do. So as you can see, New Hampshire generally has a higher operating margin than does when we look nationally. What's interesting is in New Hampshire, you see the smaller hospitals with a larger operating margin. I honestly don't know why that is, but it's an interesting fact that really drew my attention as I was looking at this. Generally speaking, smaller hospitals do have smaller operating margins, and we see that nationally. And then you can see for the sort of mid and larger hospitals, there's really actually an equivalent between national and New Hampshire. And then there's some variation at the tail end for your really larger hospitals, which again, also interesting as we look at different states' metrics. It really typically is hospitals with over 250 beds. You see around that national bar, and New Hampshire being short of that is interesting. And again, I can't tell you exactly why. I just wanted to show you the data. So now we're going to take a look at specific hospitals. And again, this is not to shame anyone. This is to provide real color to this. This is what people come to the tool to do. I have to say, like, we'll share the tool and people will go there and start plugging in their hospitals. It's the one you use. It's the one you know best. So Mary Hitchcock, I know, is a larger hospital. I also know that New Hampshire is not the only beneficiary of that hospital. We talk to Vermonters a lot, and there are a lot of Vermont users of the hospital as well. So this is looking at hospital operating costs per adjusted discharge. And as you can see, I think we're happy about this, that looking at the cost per revenue, that the hospital is doing pretty well. Revenue exceeds their costs. Now, Concord Hospital, which I believe is a slightly smaller hospital, you can see here that sort of trends together, their operating costs with their revenue, but it is starting to separate a little bit in 2021. And then Spear, which I know is a smaller hospital. And I found this particularly interesting, and the increase in both costs and revenue over time, but that the separation between costs and revenue is actually greater starting in 2021. So it will be interesting to see what happens in 22, and we can have that information for you by December. So Another point that states asked us for was the break even. So that's what I was referencing before, where state officials were saying, but how much does it cost to provide this care? And that being relatively a black box. And so again, because my colleague is an accountant, she's like, well, you need the break even. And so it just seems so simple to her. For us policy folks, we found that brilliant. But so we'll take a look at what the break even is. That's defined as what does a hospital need to make, and we do it by commercial. So if a commercial payer was going to pay what will help the hospital break even on its hospital costs, what does that look like? And as Chris already explained, doing that on a Medicare sort of rate has been extremely helpful for comparative costs, but there's already sort of built-in metrics around some of the things that hospitals have to consider, which is different acuity of care, different costs for their doctors, nurses. We use the individual hospital's Medicare rate, so those things are sort of baked in. So then we were very fortunate that RAND was doing their work to see what commercial payers paid, to talk about the difference between that break-even point and then what commercial payers paid. People, for obvious reasons, policymakers especially, are very interested in that delta. What's the difference between where a hospital meets its expenses and what they're making from a commercial payer? So here is the New Hampshire example. Again, this is national. And you can see some fluctuation over time. And then you can also see that New Hampshire's break even actually was lower than the national. I'll speak to this for just a second. And when you see individual hospitals, I think it will make more sense. But again, the break even, just to make a point, this is the amount based off the sort of Medicare payment scale that a hospital needs to cover its costs. So the fact that in 2021, a hospital needed less from a commercial payer to cover its costs, we believe is related to the infused federal funding that hospitals were getting through COVID. So because they were getting additional funds from the federal government to help them get through COVID, they actually needed less money from commercial payers to cover their costs. We saw a lot of employers, a lot of state officials said to us, why is break even going down? We're like, because they're getting more funds in. And so they need less from the federal government and from other payers. So they need less from a commercial payer to break even. We're watching this to see what happens in 2022. The theory, and again, it's still working this out, is that the break even will go up again. So as we think about this and as we tell policymakers, and by policymakers, I mean legislators, Medicaid officials, governor's office, it might make sense to average, you know, like 2020, 2021, 2022, to understand sort of what that average break even looks like. So Mary Hitchcock again, just to share, and that was following the trend line. In 2020, break even was higher. They needed more from a commercial payer to meet their overall cost for providing care. 2021, they need dramatically less. So I included the break even percentages right here as notes. I will just note, as we look at this, the national break even, just for people's reference, as you can see, is about 150% of Medicare. And we generally see that with pretty efficient hospitals, that they're breaking even pretty close to the Medicare rate. We have seen some hospitals at states' request, as we've done this analysis, where their break evens are higher than that. That would actually call into question, why can't they break even at a rate closer to Medicare? That's a whole nother policy discussion. But Mary Hitchcock is sort of what we would anticipate. I would say in 2020, that 185 is a little high, but it is probably related to COVID and what was going on during that time. So I would look at 2019, 161, and then you've got the RAND amount that's an average over those years. So you can look at that with an eye towards the delta in between. I will say the difference between the break even and the RAND commercial price paid is not their profit margin. So you have to consider some other data in order to understand what the profit is. We do have profit within the tool, but it's what I would call the place where you'd start asking questions. If you want to start talking about how to reduce the overall price for patients, you'd start asking, why is there such a difference between what you need to break even and what you're getting from commercial payers? But I do want to make the point, we are not suggesting that that's profit. There's other things going on within the hospital finances that you need to consider. So here's Concord Hospital, and I will note their break even is higher. I don't know why it's higher, but as you see something getting close to 200% of Medicare just to cover their costs, when Medicare really does, and I'm not saying it's a perfect analysis, but Medicare puts out there that they strive to pay what it costs to provide services to their patients at about 100% of their rate. So if a hospital needs sort of 2 times that in order to break even, you would have to question some of the things going on. Again, the data doesn't tell you that. A conversation would have to tell you that. And then Spear. Again, this is really interesting that Spear Hospital at this point, their break even is below 100% of Medicare. We have seen that for some others too. I will say that what that means again is that what they need from a commercial payer is to cover their costs is actually less than what Medicare pays. Now, in order to understand what's going on there, you do have to dig into the data a bit more. I would take a look at their payer mix. We have that on our tool. I would take a look at their profit, their operating profit over years to understand. And then we have a downloadable data set that's in an Excel form that provides a ton of different information that you can use. And we often, when we see something that looks like this, especially for a smaller hospital where they need less than Medicare to break even, we take a look and understand, like, are they getting in like an infuse of cash from a private donor for some reason? Because every now and then a hospital with very few beds, things can go crazy when they get like somebody has, endowed them with $5 million for a year. And it's like, you wouldn't want to make your policy based and your rate setting based off that, but you would want to understand sort of what's happening with the whole mix. And I steal this slide from Rand. I love this slide. Chris, I like your new one even better. But it does paint the picture again that there really is no correlation between what public payers pay and what private payers pay. And I know that that is something that is shared a lot. Chris already spoke to this. The one thing that I will add to that, as we talk to state officials about this payer shift, they say, when we find that Medicaid might be underpaying, and there are instances when Medicaid does underpay, when we find that Medicaid is underpaying and we make an adjustment or we do a supplemental payment to make up for some of that, we do not see a correlating change to what commercial payers are charged. So as there were some states, Colorado is one of them, that made an adjustment and they paid through their public payer, through Medicaid, more for hospitals. They did not see that there was a decrease in what charges were made to commercial. So it doesn't work, but I'll just point that out. So from my hat, I always think through, what does all of this mean? So what do you do now that you know this information about sort of healthy break even around 150% of Medicare, but a higher cost coming in from commercial? What does that mean? Generally, especially when you think about the operating profit, I think what we generally say is you could have somebody participating in a cost containment strategy with you as a state. So how do you do that? We have developed a number of different policy tools, and it really is dependent upon the state and what their data is sharing, what sort of the direction they want to go in. Obviously, transparency is incredibly important. I will just highlight that what we talk to state officials about predominantly right now is consolidation issues. How to manage a system that doesn't have competition. How do you handle that? What are some of your policy levers? And so I will just touch on one of them today. But recognizing that market power is real, and that in a situation where you have a consolidated market, where you have and it could be more than one, but you have a health system that owns hospitals, that owns providers, they have a better place to come from to negotiate with payers. By payers, I mean health plans, I mean states, I mean individuals. And so how can you manage some of that? One way that a number of states are pursuing right now is to ban anti-competitive contracting terms from contracts. So recognizing that you can't necessarily turn back the clock on consolidation, you can't unwind some of the relationships and mergers that have and affiliations that have happened. However, you could try to mitigate some of the anti-competitive behavior that happens once that takes place. So there have been instances where there are health systems that say, I know health plan, all you need is my sort of pediatrics unit to meet your health network's adequacy standard. Sorry, you have to take us all. And you don't get to pick and choose. You just have to take everybody. You have to take my hospital. You have to take my providers. You have to take all of us. And then you can't tier depending on that. You can't say this in this provider you can choose and you only pay like so much in cost sharing, and then this provider you can pay sort of more or less. Like you can't do that. We are an all or nothing contract, and we'll take our pediatrics and walk. And then you can't negotiate, you can't help your enrollees pick and choose which providers to use. You just have to have us all. Most favored nation really speaks to a dominant insurer negotiating with a dominant health system, and then gag clauses. I know there are federal bans on gag clauses, but a lot of states have opted to put gag clauses in place at the state level as well. And really that's to be more transparent in contracting terms generally. I will just note, I mean, we do have a model law. We created that at state requests. We are looking to add more contracting terms as we move forward. We're working with a work group of states who have identified some other issues. For instance, non-compete clauses for providers is something that states want to look into. I will also add that this is really a bipartisan issue as states are looking at this. They just want to make the market a more fair place for health plans to negotiate with big health providers to get better rates for consumers. And so we see that Texas took up this law, Connecticut took up this law, Nevada has this law in place now. We learned from Massachusetts for this. And then we also have been working with some states that are taking one or two of these clauses. And that's what the model was developed for, whatever is important to that state. We have others online too. That sort of slide I showed you with all of those policy options, NASHP has information on each of those. We don't have model laws for each of those, but and then the tool is right there for you to use and interact with. But that's it.
So I wanted to invite all of our presenters here for the panel discussion, and I'm really hoping that either people online or here in person have some questions for them. I know I have lots of questions, but I don't want to be self-serving that way. And I also don't want to channel my inner professor and start calling on people like George and Lindsay and Jen and Alex. So I'd like to say, I think we have a couple of questions submitted through Teams. And if anybody here has questions, just put your hand up and we'll have you kind of somebody bring up an index card. Heidi, you write small. And I see poorly, so that combined, you'll have to be patient for a moment. Okay. So I'll ask this to you all, and then we can find the most appropriate responder. Okay, so what more can be done to place a bigger spotlight on the findings from multiple studies that show that hospitals are making up drugs, including specialty drugs, by marking up drugs by at least 200 to 400% under the buy and bill model. Are the transparency tools providing transparency on the difference between hospitals' large markups and lower drug prices through specialty pharmacies that are not affiliated with hospitals?
You want me to take that? So I will share, I am not NASHP's drug expert, but NASHP's drug experts work on my team. So understanding drug costs and markups are incredibly challenging. I can't blame hospitals for that. One of the issues is that there are sort of proprietary issues related to manufacturer prices. Then you have the opaque situation with PBMs. I don't mean to just blame PBMs, but you start with not being able to understand the manufacturer price completely. Then it works through the drug supply chain in the way that it interacts. And then you get to the hospital side. And there is some markups even at the hospital side, but there's also the drug rebates that come into play. And then there's also the 340B program, which I won't walk through right now, but exists and makes it even more complicated. So I don't know of a study that highlights exactly beginning to end, and then who within that supply chain benefits the most from all of these the lack of transparency. What I will say is that there are states that are moving in a direction to really understand drug price issues. I would point to Oregon in particular has a really impressive prescription drug price transparency program. There's limits to what they can publish because of all of the proprietary rules and laws. And then there's interstate issues with some of these things. Then there's also the states that are creating their own prescription drug review boards. I know New Hampshire is one of those. And they are a small but mighty group, and they are looking to eventually, there are some states that already have this authority to set an upper payment limit, and then they are considering if they have that authority, and I believe there's only a couple that do, they have that authority that is being taken extremely seriously and looking at a lot of different resources to understand the value of the medication, what that price should be, and what that payment eventually will be. And so we're all watching Colorado right now. Colorado is the state that currently has named 5 drugs, and I don't know them off the top of my head, that they are doing an affordability review for. And then they'll understand more about how they're going to set their upper payment limit. And they're considering all of these different factors. So specialty drugs, whether they're provided at a hospital, and all of those things. I'm sorry, this is an unsatisfactory answer, but I just want to paint the picture that there is work being done to figure this out. It's just not a simple thing to do.
If I could chime in on that. So we have some forthcoming work looking at this exact question for clinician administered drugs, and the markups we see for clinician administered drugs are actually pretty similar to what we see for everything else in healthcare for dominant hospitals, where the price markups are 300 to 400%, and then add the 340B and buy and bill incentives, and it's a whack-a-mole.
Thank you for your question, Ms. Kroll. We have another question. In light of the break-even data, what elements should observers look at to understand the overall efficiency of a hospital?
So I think the break-even data provides you some baseline to go from. So if you've got a hospital that is breaking even at 115% of Medicare, and then you've got a hospital that's breaking even at 200% of Medicare, it does just jog the question, what is the difference? Why is that happening? I would first, and this is what I tell people to do, first look at how many beds we're talking about. Again, hospitals with more beds tend to have more resources. That's not a rule, but just take that into consideration. I would also take a look at payer mix. We've seen some, again, I don't believe there's a correlation between what commercial payers will pay. I think that's what the market bears. But if you are looking at a state that has an expanded Medicaid, for instance, and you have more individuals that are uninsured, that can have an effect on what you need from commercial payers to break even, because you may not have enough payers, period, public or private, in order to cover those costs. And so some of the other things I would look at truly is, what is the operating profit margin over time? How has that changed? We also take a look to see if there has been a recent purchase or acquisition that may have, for the larger system, that may have something to do with what the break even. It's like if you see something strange in a particular year. So there's a few different things to consider, but you do have to consider multiple things. And honestly, I really do think it's just an opportunity for payers, purchasers, or policymakers to say, we have a better understanding of where you're coming from, so we can start having these conversations. It just is meant to provide a more even playing field and more transparency.
Thank you, Maureen. I'd like to point this next question to Dr. Brown because it aligned with his presentation. It's a great question. How does moral hazard, or the moral hazard concept, impact the incentives for individuals to seek competitive prices?
Yeah, that's a good question. So, when individuals when there's kind of low cost sharing, out-of-pocket costs are likely going to be similar across providers. There's not going to be much incentive to price shop. And I think that's why we've seen there's now kind of a few papers that have shown that really the patients that have an incentive to price shop are those that face significant out-of-pocket costs, such as those with high deductible health plans. And so I think there is definitely this moral hazard effect where certainly we want insurance that provides good coverage. At the same time, those individuals don't have much incentive to shop. I think something like health savings accounts where, patients see the benefit of shopping and get some of that money back, I think could increase their incentive to use these tools.
Thank you, Dr. Brown. Anybody else on that one? Thank you for that response and that question. Okay, so to all of you, where do you expect the greatest price pressure, either positive or negative, to come from? Consumers, regulators, or state agencies such as HPC, or the legislature?
So I think if we kind of rank where price transparency will have the large impact, I think if we start with consumers, there's probably not going to be much of an impact. Just the idea that you give patients, when they're already dealing with one of the most stressful times in their life, another online tool to use, and that's going to magically change the healthcare system. I don't think that quite is going to work out. So maybe the consumers will save us 1 to 2% of spending, if that. Employers will probably have some bite on markets through benefit designs, but any employer has already got a million things going on and just has limited scope within their market. And so I think the real impacts of price transparency are really on the regulatory side and making sure that markets are competitive, and a lot of the adverse consequences of consolidation and many of the contracting aspects that Maureen discussed don't exist.
Thank you. Another question. So is there any correlation between hospital pricing and median income of a community where a hospital is located?
There is, so in hospital pricing, there's always rules and exceptions to those rules. And so I'd say if we look at income and hospital prices, we don't see a clear relationship. So for example, South Carolina is a lower income state, and we saw that as well as West Virginia, and we saw that had the highest prices. And if we look at, say, for example, in California, or the best example of hospital pricing dynamics I have is from California, where if you divide a line in the middle of California, Northern California is very high priced. Southern California actually has pretty competitive hospital prices. The incomes, labor costs, et cetera, are pretty similar between Northern and Southern California. It's just that Northern California is incredibly concentrated and has a handful of hospital systems that have lots of market power, while Southern California is actually a pretty competitive hospital market. And so I think that's the real driver of hospital cost prices.
And I think this one might be pointed back again at Dr. Brown. Great question. Are there any data to indicate how or maybe when consumers learn about and then use the transparency tool?
So it's hard to kind of link, say, like website traffic data to say claims data. I'm not aware of anyone that's been able to do that. And so it is hard to see who is using these tools. I think, again, I'll just reiterate that there does seem to be some evidence that it's those with, say, deductibles that are gaining the most from these tools. That's where we really see the action in terms of lower out-of-pocket costs. So these seem to be the individuals that are using the tools. The other thing that's difficult that I'll just mention is it's not just about someone actually going to the website and using it. It's also, you could imagine through word of mouth, people kind of learn about, which are the lower cost providers. And even without using the tool, that could kind of increase knowledge in the general population.
Another question. So have there been any efforts to get providers to post the link to the transparency tool and or promote the use of the tool?
I think that's a question for you.
Well, yeah, we've seen a few reports that, describe spurious compliance with both the hospital price transparency tool and the transparency and coverage tool. Yet we've not really seen a lot of convincing evidence or comprehensive studies assessing that. So I think that because this new legislation, the verdict is out on that. And I work with Alex on some of that stuff. I don't know if you have something to say about that, but we're eager to learn more about the compliance with that because it's an important advent in state and federal government. So if indeed a cost transparency approach is successful at putting downward pressure on cost, how do those savings get appreciated by people with commercial insurance?
I mean, so we know that, especially for those with commercial insurance, healthcare premiums come out of wages. And so that's one benefit, higher wages instead of premiums. And then as Zach mentioned, those who have high cost sharing can also directly save through lower cost sharing payments.
And I can jump in and just say, and this is very unique to certain states, but NASHP has been convening state employee health plans. So a unique kind of health plan, a unique kind of state employee plan. But some of what they're trying to do is and again, it depends on the state, not everybody's doing everything the same, but as a state plan is trying to incentivize wellness benefits and then trying to help encourage people to use those benefits by taking away all cost sharing, things like that. So there's certain ways that an employer could help drive people to use certain care. And again, obviously what Chris said, I mean, if you can save money in driving somebody or better negotiating with a health system to lower prices, you would hope that premiums come down from that. But there are some benefit design things that employers are trying to.
Thank you, Maureen. Another question pointed right to you, Maureen. So you mentioned that a few of the states have enacted anti-competitive contracting prohibition policies. Are there one or two states in particular that have gotten this right in reaping the benefits?
So to another terrible answer. It's relatively new to be taking this approach in this way, like prohibiting all of these anti-competitive provisions at once. So California has done it, but very recently, so we don't see the results of that yet. Texas literally did it months ago, so we don't see the results of that yet. But I will say Massachusetts has had some things on the books for a while, and we do see that they're on the RAND study that they are on the better side of what employers are paying. I'm not saying it's perfect, but as we look at some of these pieces where it's like, as we take a look at where the RAND data shows that employers are paying less and the break even is still very good, like they're very efficient hospitals, they're around the Medicare, 100% of Medicare for their break even. We start looking at those states and we're like, what policies have they put in place? And again, there's no silver bullet, or I would tell you what it was. But so there are some states that have been reflecting better data that have some of these provisions in place.
Okay, I think our last question. So New Hampshire has a growing self-funded large group health plan population. What strategies are states pursuing despite this? And what strategies help self-funded employers meeting fiduciary responsibilities around access and cost?
So I think for the self-funded employers, the number one thing is to know what's going on under the hood in terms of contracts that are negotiated on your behalf. And so that's where we've been able to, I think, work well with self-funded employers and say, these are what the prices look like in your population and in your network. And it's important to recognize that we as researchers, I don't think, do a very good job of saying your prices are too high or too low, and it's really up for the employer to see the range of prices, know their market and know their population, and to understand or at least make that judgment call on how they view the appropriateness of the prices that are being paid for by the workforce. The second area that I think self-funded employers can engage more has to do with the recent Consolidation Appropriations Act of 2021, which actually does do a lot to think about how employers receive benefits and what are the potential conflicts of interest in the brokers, advisors, and third-party administrators that could potentially unduly influence how employers purchase benefits. And so self-funded employers now actually have to attest that they've reviewed any potential conflicts of interest. And I think doing the best on understanding that role is important for self-funded employers.
Thank you. So before we enter our public hearing, public comment period of the hearing, I just wanted to give our presenters an opportunity to make any closing remarks or comments, if you have any.
I guess the only thing I would say is just thank you for having this hearing and thank you for spending time and attention on this issue. I think that's honestly some of the best things that a state can do is just start having these conversations. So I appreciate the time that everybody has taken and the resources the state is putting towards this.
And I'd like to thank all three of you for advancing our understanding on this important and yet complex set of topics. I think everybody who attended today's hearing is better because of it, and I'm thankful for your presence. So let's give them a hand. So now is the public comment period. If anybody has any public comments now, and you'll also have a week to be able to submit your comments in writing to the insurance department. So you have until Friday, November 3rd to submit any comments in writing. If anybody here, either online or in person, has comments, then it would be a good opportunity to state them now. Well, thank you so much for attending. I know I got a lot out of this. I hope you did too. I think our special presenters, our commissioner has some closing comments, and we'll see you next year. Thank you.
Just very briefly, I want to echo what Dr. Raz has said in thanking everybody for attending. I think this is one of our higher in-person attendance, certainly in the years that I've been here, which is great. But of course, we appreciate the folks who have joined us online as well. I would just note that, as you probably saw, we did the second half of this presentation a little bit differently than we had in the past. Typically, we would pick a topic, we would have the carriers or representatives from the carriers come down. We would torture them for a little while. We would then let you torture them for a little while. We decided to do something a little bit different this year. We do want to keep this event fresh. You're always going to have Jen and Don, of course, but the second half of it, we really want to design to make sure that folks are getting the most out of this. And I think today was a very successful event. But my point in this is, if you have suggestions as to how we might, again, keep this program fresh, informative, we're ensuring that we're addressing critical issues, please do let us know. We want that feedback. We want your collective wisdom, if you will. And the last thing I would say is, we overheard a comment earlier about how it would be really advantageous to have some policymakers here in the room. We do invite them. I know of one key member of the legislature who I learned is in Amsterdam. He was having dinner in Amsterdam when we reached out to him. Somehow, I don't think he'll have an earpiece in watching this event as he's doing that, but we do invite them. And what I am going to do is have Andrew email out to all of the members of the legislature and the governor's office the presentation, the link to the presentation, and we will obviously encourage them to watch it and take notes. So with that said, again, thank you all for coming out. Look forward to working with you, and we'll see you next year. Thank you.